recognize that we as health systems don't own all of this, that we have to work with other sectors of the healthcare economy and other partners that we have within our communities. And let's pace this in a thoughtful way so that we don't lose momentum and we keep leaning into this, but we also recognize that there are a lot of interdependencies here, and we've got to do this very carefully and thoughtfully. When I talk to our 16,000 employees about why affordability is an important issue, I use the example of my daughter. So my daughter, Kate, when she came off of our health insurance plan, my employer-based health insurance plan, she was living in Wyoming. And she worked as a physical therapy assistant and was making $19,000 a year. And I now know what it's like to look at an exchange product and get her on an exchange product and help her go through that process. But what I recognize there is that her monthly payments right now on an exchange are $400. And that is for a plan that has a $5,000 deductible. Now, because of her income level, she's received subsidies. So her actual payment is $100. But if you add the two numbers up, she has $6,200 of financial exposure on a $19,000 gross income. And so that's the real affordability issue, where people and families are having to make significant trade-offs right now between food, between clothing, between housing and healthcare. And that makes this issue very real. I am really enthusiastic about the work we've done in the last 4 years in collaboration with over 2,700 physicians in our region in developing our ACOs. And we've had 4 consecutive years of shared savings through the Medicare program, but we were also running commercial activity through that. So we have almost 400,000 attributed lives in 2 ACOs. It makes us, I think, the 4th largest in the country. And last year we were 10% of the total Medicare savings. And we have about 90,000 Medicare beneficiaries in that group. And what's been so important to me is how everybody has been working together to move this forward, how we've made the kinds of investments in data and care management activities to make this successful, and how it is really transforming care within our organization. Now, the interesting tension that emerges when you've got the ACO leadership and you've got our hospitals leaders together is, kind of the running joke is, yeah, the ACOs are doing great, but our volumes are down in the hospitals. And I think what's important is to stay focused on the number of individuals that we are touching every year, that we're caring for every year. And my comment to our staff as we go through this is, if we pay attention to the number of people that we're caring for, as opposed to how many surgeries we're doing or how many admissions we have, and then we pay attention within our ACOs to the percentage of care that they're receiving within our system, we can grow the number of lives, and then we can grow the retention rate of care within our system, and that really will begin to offset the volume that is being pulled away because we're providing more efficient care. And once again, that's kind of an aha when you begin to think of it that way, because people worry about, well, if we're cutting down our admissions per thousand, or if we're reducing utilization of labs and tests, that we're not going to be able to use the fixed assets that we have in our organization. But the real argument is, how do we create ourselves in a way that we are indispensable to patients so that they turn to us because they trust us for care, we keep them within the system, and more people come to us. And that's really what we're doing. And so our work in the ACOs, it's just teaching us a whole new way of thinking, and I'm very, very excited about that. So we've got some things that work in real time, and in our community hospitals where it's hard to get coverage by intensivists for our patients, particularly in the evenings and nights, we're using telehealth in a way that our care is dramatically safer. As I do rounds in those hospitals, after we've put in a tele-ICU where our staff can literally push a button on a wall, a camera comes on, a physician is there, the quality of both the monitoring, she sees every monitor we have, she's in our electronic record, and through the camera that we have in the patient's room, you can look down to the size of the patient's pupil. And because of that, our nursing staff feel like they've got immediate coverage around them. And we've had this in place for a couple of years now in some of the ICUs. And when I round with staff, I say, is care safer today? And uniformly, the answer is yes. And then lo and behold, more patients are actually staying in that community for care rather than getting transferred into our tertiary care centers. And because of that, it's more convenient for their families. And ultimately, it's a lower cost. So I think that telehealth is a great innovation, and there's many ways to use telehealth. But I think that one hits all the buttons. The other thing that I think is emerging, which has so much promise, is to really begin to use artificial intelligence to help make better decisions. And it doesn't replace judgment, it doesn't replace critical thinking skills as it relates to our providers, but what it does is it synthesizes down so many inputs of things that are coming through. Just look at the number of drugs that come on the market every year, or the nuances around genomics. And so if we can use artificial intelligence to help narrow down the path, it, number one, provides more contemporary and better care for our patients in a consistent way, but it also helps our providers really be able to spend more time on the ambiguous activities that they need to address clinically with a patient, because they've kind of sorted through all of the other things. And I think that holds so much promise that we're making investments in that.